We are an open access virtual initiative to educate trainees on clinical research studies pertinent to VIR through monthly journal club sessions. Each TNVIRJC session focuses on a randomized clinical trial or meta-analysis, so level 1 evidence, accompanied by an overview of the relevant disease and intervention. So now I'm going to let our presenters, Emily and Ella, introduce themselves as well as their faculty mentor.
Okay, hi everyone. My name is Emily Jagenburg. I'm a third-year medical student at Oakland University Beaumont School of Medicine, and I'm working with Ella Zhang from Yale, and our faculty facilitator is Fabian Guapp. And today we're going to be talking about the collision trial, which is surgery versus thermal ablation for small-sized colorectal liver metastasis. Okay, so just a little outline for today. So first we're going to talk about the clinical background of colorectal liver mets, and then we'll talk about the collision trial in detail, followed by references and then Q&A. Okay, so a little bit about our faculty facilitator. He's an interventional radiologist and assistant professor of radiology and biomedical imaging at Yale Institute for Global Health. And a little bit about his academic background. He got his MD at Ludwig Maximilians University in Germany, his intern year at New York Presbyterian Hospital, and then residency in interventional radiology at Yale New Haven Hospital. And then his previous projects of note is he is the co-founder of Road to IR in Tanzania and Uganda. Okay, so a little bit about some epidemiology. So the incidence of colorectal liver mets in the United States is 154,000 annually, new cases. In comparison, New York City, it's about 3,400 new cases per year. And about 20% of patients are metastatic at diagnosis. Interestingly, the incidence is rising in young adults under 50 years of age. So there's about 20,000 new cases and about 4,000 deaths in 2023. And then below in the figure, you can compare colorectal and lung, cervical, breast incidence and mortality. Okay, so some clinical importance. So the liver is the most frequent site of colorectal cancer metastasis. About 25% of patients, again, develop liver mets. And most liver recurrences occur within 3 years of primary resection. However, most metastatic disease remains limited to the liver. And also, interestingly, there is a difference between genders in terms of incidence of colorectal liver mets, being it more common in men. Okay, so just some pathophysiology. So it's hematogenous spread via the portal vein, and this is called the seed and soil hypothesis. But there's 3 predominant patterns. So there's the pushing pattern, which is where the tumor mass expands and compresses the surrounding liver tissue. This creates a smooth pushing border compared to the desmoplastic pattern, where there is a fibrous border separating the tumor from the liver. In the pushing pattern, the tumor simply pushes on the normal liver tissue. And then again, the desmoplastic pattern, the tumor is surrounded by a thick rim of fibrous tissue, also known as stroma, which separates the cancer cells from the normal liver tissue. So this fibrous barrier often contains immune cells and new blood vessels, and this is associated with a better prognosis. And then there's the replacement pattern, simply where the cancer cells replace the normal parenchyma, and this is associated with a worse prognosis. Okay, so just a little bit about the clinical presentation. So if a patient is caught early, they're often asymptomatic. And again, 20 to 30% of patients are asymptomatic at time of colorectal liver met detection. And this is often found incidentally during regular colorectal cancer imaging surveillance. But if they miss their surveillance imaging for whatever reason, they may be symptomatic or just otherwise symptomatic. And this is usually if they have metastatic disease, of course. So this would present with right upper quadrant pain most commonly, weight loss, fatigue, and then jaundice specifically if there's biliary obstruction. And then for labs, there's elevated CEA, and that's present about 60 to 70% of the time. Okay, so a little bit about the diagnostic workup and how this would look in different imaging modalities. So for CT, you would see a hypoattenuating lesion with peripheral enhancement. The pros is that this is widely available, and the con, of course, is it has high radiation dose. For MRI, it would be T1 hypointense, T2 hyperintense with restricted diffusion. It has superior sensitivity compared to CT at 92% versus 78, but of course, there's limited availability, which is the big con. And then contrast enhanced ultrasound shows a hypervascular rim with a washout in the late phase. The pro is no radiation and real-time guidance. Okay, so the diagnostic workup. So of course, a baseline CT and MRI for staging, and then PET CT for suspected extrahepatic disease. Biopsy can be done for a couple of reasons. First, if imaging's inconclusive. Second, if the primary tumor is unknown. Third, sometimes it's needed for molecular subtyping or clinical trials. And also, this is just frequently done at tertiary centers like Yale, even when the colorectal origin is likely. All right, so some treatment options for this. I wanted to stratify this by 5-year survival. So if you look at surgery, which is hepatectomy or segmenectomy, the survival is 25 to 50%. And then candidates for this would be if it's, of course, in a resectable location. And in addition, if there's less than 3 lesions and they're close in proximity to each other, and peripheral lesions are easier to resect than central lesions. For medical therapy, it's for unresectable or adjuvant to either surgery or IR ablation, and the 5-year survival is 10 to 15%. And then IR ablation, which is what this whole thing's about, examples would be microwave or radiofrequency ablation. And then candidates for this approach is if the mass or lesion is less than 3 centimeters in size, and then central lesions. And then of note, just central lesions are often more challenging to ablate due to proximity to major vessels and bile ducts. Peripheral lesions are technically easier and often safer to treat. So the decision on which treatment modality is usually made by a multidisciplinary team with a lot of factors taken into account. But the 5-year survival for IR ablation is 30 to 40%. Okay, so we just wanted to show you guys what this actually looks like. So hopefully this works.
At the later phase, we can see the washout on the tumor. We're bien in apnée. You can see the needle at the entrance. We are now after roughly 3 minutes and 30 seconds of treatment, and we can see the progress in size of the ablation zone.
Okay. Whoops. All right. So the current standard of care for colorectal liver mets. So per the ASCO and ESMO guidelines, surgery is still the gold standard for resectable disease. However, only 10 to 20% of patients are surgical candidates due to disease extent or comorbidities. So non-surgical patients undergo either systemic therapy and local ablation. Of note, in terms of margins, you're looking for about 5 to 10 millimeter margins for complete treatment, with 10 millimeters being ideal for ablation. Okay, so I just wanted to point this out, and then I'll talk more about exactly what thermoablation is on the slide. So this is an app you can actually download. It's called Medtronic Imprint. And what it lets you do, I'm actually changing here, it's a screen recording of the power or watts, and then the time of which I'd want to ablate. And you can see how it's changing the ablation cavity dimensions. So this can be helpful for procedural planning. So anyway, radiofrequency ablation and microwave ablation use heat to destroy tumor tissue and can be performed percutaneously, laparoscopically, or during surgery. So this is indicated for unresectable liver tumors, comorbid patients, small, again, less than 3 millimeters in size, or patient preference. It's less invasive than surgery with shorter hospital stays and fewer complications. And advances in microwave ablation have improved tumor control and reduced prior concerns about recurrence. Okay, so just a little bit of telling you the difference between microwave and radiofrequency ablation. So microwave ablation uses electromagnetic waves to generate heat, whereas radiofrequency ablation uses high frequency alternating current to generate heat. And the ideal lesions for MWA, I'll just call it for now, is larger, deeper, and more central lesions, whereas RFA, smaller peripheral tumors. And then microwave ablation tends to be a little bit shorter in terms of the procedure time compared to RFA. The heat sink effect, which I'll go into in detail in the next slide, basically it's if it's close to a large vessel, it can mess with the ablation zone, but again, I'll explain that in detail in just a second. The microwave ablation is less affected compared to radiofrequency ablation. And just of note, to sum it up, so when would you use MWA for lesions that are greater than 3 centimeters in size, and then RFA less than 3 centimeters in size, or low flow areas? And just overall, MWA is favored due to high flow central areas due to greater resistance to heat sink. And then you're still looking for that 5 to 10 millimeter margin. All right, so this is the heat sink where I told you I'd explain it. So for IR treatment, you're going to do the CT MRI to map the vasculature. And then again, you're going to avoid vessels if they're greater than 3 millimeters in size and near the lesion due to this heat sink effect that I was talking about. Because essentially it reduces the efficacy of ablation. And the heat sink effect is where large vessels dissipate ablation heat, and this can cause incomplete tumor necrosis. And this is more pronounced in RFA than MWA. And then I have this figure here to sort of detail that. So just ablation selection by tumor size and location. So I sort of talked about this already, but if it's less than 3 centimeters in size and peripheral, RFA is the best modality. If it's near a vessel, MWA is better because it has less of that heat sink effect. And then if it's larger than 3 centimeters or central, MWA. And then if it's greater than 3 centimeters in size or multifocal or deep, it would be a better candidate for Y90. And then again, the selection of what type of IR procedure you're going to do depends on a lot of things: size, location, flow dynamics, and overall liver function. So it's not just as simple as this chart, but I wanted to give you guys a way to understand this. So I wanted to do a case example. So this is a pre, post, and 1 year follow-up from microwave ablation done at Cornwall Hospital in Royal Oak, Michigan. So, of course, the red arrow, you can see the tumor. And then on the post, you can see the ablation zone, which is black. And then you could see on 1 year follow-up, there's no recurrence of the cancer. And you could see that ablation zone sort of shrunk down. If you're wondering what's going on the far right of the liver, that's a previous Y90. Okay, so post-procedure management. So immediately it's about a 4-hour observation for percutaneous ablation, and then pain control for about 72 hours with NSAIDs, or some interventionalists may opt for a different medication such as opiates. And then for follow-up labs, you can do CEA at 1 month and then every 3 months afterwards. And for imaging, you're going to do serial imaging with CT and or MRI at 1, 3, 6, and then 12 months. So some complications you could look out for. So the most common and earliest complication, of course, is bleeding, pretty common with any IR procedure. And then in addition, you can have, of course, a fever, which could indicate perhaps an abscess. And a bilirubin spike could indicate a biliary injury, and this is particularly important if your ablation zone is either in the center of the liver, like we talked about, or if it's sort of inferior and near the gallbladder. All right, and now I'll hand it off to Ella. Thanks.
Thanks, Emily, for the great introduction and explanation about colorectal liver metastases. Now we're going to dive deeper into the collision trial. So this is a trial that was specifically looking at the efficacy of surgery versus thermal ablation for treating patients with colorectal liver mets. And this was an international multi-center phase 3 randomized controlled trial done across 16 centers in Europe. And the principal investigator was Dr. Meyerinck, who's an interventional radiologist from Amsterdam UMC. The findings from this trial were presented at ASCO last year, and they had a recent publication in The Lancet earlier this year. Next slide, please. Perfect. So the goal of this study was not necessarily to prove the superiority of thermal ablation over surgical resection, but rather its non-inferiority as a less invasive procedure. So specifically, they wanted to evaluate thermal ablation versus surgical resection as far as patients' overall survival, as well as also confirming that thermal ablation was indeed a less invasive technique by evaluating patients' complication rates, adverse events, overall hospital stay, as well as quality of life. And just for reference, when I talk about thermal ablation here, I include both microwave and radiofrequency ablation, but typically I think microwave ablation was more frequently done in most of the patients in this trial. Next slide, please. So patients were enrolled between August 2017 and February 2024 across 16 centers in the Netherlands, Belgium, and Italy, although they were only treated at 14 of these 16 centers. In total, 300 patients were enrolled, and the inclusion criteria required that all patients were over 18 years old with 1 to 10 colorectal liver metastases less than 3 centimeters in diameter. The majority of the mets had to be target tumors. So target tumors are defined as both resectable and ablatable, but some non-target tumors were also allowed as long as all unablatable tumors were considered resectable, and vice versa, all unresectable tumors were considered ablatable. And resectability was evaluated by expert surgical panel. And as Emily did a really good job of explaining earlier, resectability is typically determined by the location of the tumor, so whether it's deep-seated or superficial in the liver. And similarly, ablatability was evaluated by an expert interventional radiology panel. The highest contradictions for ablatability was if the tumor was too close to vessels or the central bile ducts, again, referencing that heat sink effect we talked about earlier. No patients were allowed to have extrahepatic metastases. All patients had to have an ECOG status greater than 2. ECOG is just an assessment of the patient's functional status and is typically used for assessing cancer patients in particular. And finally, all patients had to have a life expectancy of at least 12 weeks or greater. Patients were randomly assigned to either thermal ablation or surgical resection groups. Each group consisted of approximately equal numbers of patients with low, intermediate, and high disease burden. So low disease burden was defined as patients having 1 to 3 metastases, with all of the mets being target tumors. Intermediate disease burden was defined as patients having 1 to 4 tumors with at least 1 non-target tumor. And patients with high disease burden had basically the same criteria as the intermediate group. However, if they received the surgical resection, a major hepatectomy would have been required and performed. So we originally started with 300 patients. 4 patients, 2 in each treatment group, were excluded after randomization because they were found to have other disease pathology. So they had mets of other origins other than colorectal. And finally, I just wanted to note that a few of the patients in the thermal ablation group were also found to have at least 1 lesion that would have been better resected. So these patients had the majority of their metastases ablated, and then the 1 lesion that was really strongly indicated for resection was surgically resected. But overall, there were 148 patients in each of the treatment groups. Next slide, please. Thanks. So all of the surgeons and interventional radiologists involved in the trial were encouraged to use the systems that they knew the best and were most comfortable with to prioritize patient outcomes and kind of prevent against any bias in the results due to physicians not being comfortable with the procedures being used in the trial. So as you can see, I've listed here, there were quite a variety of techniques being used in the trial. I've illustrated some of these in the figure on the right. So you can see there was percutaneous ablation, laparoscopic methods, as well as open surgical resection. And of note, the margins for ablations were reported. They were mandated to be reported for all of the ablations. And they were also highly predictive of tumor recurrence. So ablations with margins greater than 5 millimeters had a 96% chance of non-recurrence. And all of these procedures were done during a single session. For follow-up, all patients received cross-sectional imaging, so CT or MRI with contrast. They also had labs specifically looking for carcinoembryonic antigen, or CEA. This is just a biomarker for colorectal cancer. And all patients also completed quality of life and health economics related questionnaires at baseline, every 3 months for the first year, and every 6 months thereafter. Next slide, please. So now getting to the results, these are the results that were determined at the halftime point of the trial. So you can see based on these curves that there's no significant difference for survival outcomes between surgical resection and thermal ablation for overall survival, as well as local and distant tumor progression-free survival, which is basically the time until cancer progresses to a more advanced stage, either at the locally treated site or at a site distant from the locally treated site. Hazard ratios were really close to 1 for all of these comparisons, and you can just visually see that the lines are very much overlapping for a majority of these Kaplan-Meier curves. So these were kind of the results that the researchers more or less expected, but the most surprising finding for them can be seen in panel D, where local control was also not significantly different between resection and ablation in the per patient analysis. And thermal ablation was even superior to surgical resection in the per tumor analysis. So loss of local control was observed in only 1 patient in the thermal ablation group, whereas it was observed in 7 patients in the surgical resection group. And this finding was really surprising for the researchers because it's typically traditionally thought that you are less likely to have recurrence along surgical margins compared to ablation margins. And based on a lot of previous findings, the researchers thought that thermal ablation would have higher rates of recurrence or progression in the areas where the tumor was originally located. Evidently, this was not the case, and the researchers of the study hypothesized that it might be because one, recurrence along surgical margins for diagnostic radiologists might be harder to detect due to PET variability. Apparently, the PET signal is more dispersed along those margins. And second, recurrence might be more difficult to treat for patients who receive surgical resection just because it's more often deep-seated, so more difficult to detect and also harder to treat. Next slide, please. And we can also see that there are far fewer adverse events in patients who are treated with thermal ablation. So first, just to back up, surgical resection compared to thermal ablation, surgical resection had higher all-cause 90-day mortality as well as treatment-specific 90-day mortality. And patients who received surgical resection had also experienced a higher total number of adverse events compared to patients who were treated with thermal ablation. And they also experienced higher rates of serious adverse events as well. Serious adverse events include periprocedural hemorrhage requiring intervention, as well as infectious complications requiring intervention. So these serious adverse events affected 20% of the surgical resection group, which has been, it's pretty consistent in the previous literature, as compared to thermal ablation, only 7% of patients experienced serious adverse events. And finally, just looking at the length of hospital stay, patients who received the surgical resection stayed on average 3 days longer than patients who received the thermal ablation. So a bit of a difference in quality of life as well. Next slide, please. So the trial was stopped early because it had a high likelihood, over 90% chance of proving non-inferiority of thermal ablation as far as overall control, as well overall survival, as well as local control. In addition, thermal ablation was also proven to have fewer complications and adverse events compared to surgical resections. So for ethical reasons, the collision trial was stopped at the halfway point. So that's where I presented the results earlier. Next slide, please. So overall, the results from the study challenged previous assumptions that favored surgical resection over thermal ablation. And according to the principal investigator of the trial, the EORTC, which is the European Organization for kind of performing and validating guidelines for research and treatment of cancer, they will be releasing new guidelines that suggest resection and thermal ablation should be considered as equally effective. Next slide, please. I briefly just wanted to touch on the limitations of the study. So first, since the trial was stopped early, it can be difficult to draw definitive conclusions just because the timeline was just simply not as long as they were originally anticipating. Also, it's unclear if a certain subset of patients might have benefited more from surgical resection since that wasn't the primary area that they were investigating. Third, the study was not powered to assess differences in ablation approaches. So open, laparoscopic, or percutaneous, they were all methods that were used in the trial, with or without needle guidance, radiofrequency versus microwave ablation. They didn't really look at to see if there were any differences in those approaches. And also the study didn't examine specifically differences between ablation alone versus ablation with resection, since a small subset of patients did receive both options. And fourth, all of the patients in the study had induction chemotherapy performed, which may impact comparisons with patients in other geographical regions where this may or may not be the standard of care for patients with colorectal liver mets. Next slide, please. So just to kind of wrap this up, the results of the collision trial indicate that we should reconsider the previously held assumptions that thermal ablation should only be used for unresectable colorectal liver metastases. And the authors of this trial suggest that physicians should ideally offer both treatment options to their patients and discuss the pros and cons of each on an individual basis. I think as we can see, the collision trial shows that there are a lot of new spaces for interventional radiology and oncology to expand into. The authors of the collision trial are currently conducting another trial called Collision XL that focuses on the differences between thermal ablation and stereotactic body radiotherapy, or SBRT, for larger size and unresectable colorectal liver mets. And finally, I listened to a podcast that the principal investigator gave on the Backtable podcast, and he really emphasized the importance of standardizing intervention quality, not only across the nation, but globally as well, and also emphasized the importance of being present in tumor boards to ensure optimal level patient care between interventional radiologists and surgeons. But finally, he wanted to highlight that this trial really shows that there's potential for interventional oncology to enter a so-called golden area for treatment, really expanding the current procedures available for patients to receive high-level treatment. So the next slide just lists some of our references. And yeah, that about wraps up our presentation. Thank you all so much for your attention, and we're happy to open the floor to questions at this time.
Great job, guys. Really, really nicely presented. I think this was very, very comprehensive and also like very, very nice introduction, really easy to understand.
Thank you.
I can kick off questions. The question I have is about the number of METs. I know that patients included in the study had anywhere from 1 to 10, but I was kind of wondering the clinical significance of number of METs. For example, a patient that has 3 versus someone that has 9. Is that something that in real practice affects like survival rates or complication rates? And do you think that, or do you know if they randomize or match for number of METs, or do you think that could be a like clinically like a confounding variable?
You want to take that, Ella?
I mean, I can't give like the clinical perspective, but at least from the trial's perspective, I don't think they matched the patients as far as how many mets they had, but they did do per patient analyses as well as per tumor analyses. So I think they kind of controlled for that in some way in the per tumor analyses, given that some patients, if they were in the low disease burden, they only had 1 to 3 mets versus in the high disease burden, they might have had greater number of mets as well as those tumors being treated in a variety of different ways as well.
Exactly. I mean, they had those 3 subgroups, right? So that kind of answers the question, And what was it? The low risk group, was it 1 to 3, and then if above, I can't remember exactly what the groups were.
Yeah.
But in that sense, they basically try to match the group sizes within the experimental and control group. And I think, the vast majority were in the lower risk group, right?
Yeah, majority of patients were low disease burden, and I don't think they found any significant differences between the patient subgroups. So it looked like the number of mets didn't really affect overall survival or any of the parameters that they were looking at in this trial.
Thank you.
It's really good to know. There is a question from the chat. So, based on the findings of the study, is there helpful language the care team can use in the clinic to counsel patients on the selection of the treatment protocol? For example, if they're hesitant about ablation over normal resection.
Sorry, what was that question for me? I don't hear anything.
Hi, sorry, can you guys hear me?
Yes.
Okay.
What was the question?
A question in the chat about whether there's any helpful language that the care team can use in the clinic to counsel patients on the selection of treatment protocol. So, like if they're hesitant about ablation, or if they're hesitant about normal resection.
Yeah, I think this is also one of the messages of the paper is like, you can achieve similar outcomes with different approaches, and a lot of these decisions are ultimately gonna come down to local expertise, right? So, if you're at a center where, overall, of course, the trial found that you have lower complication rates with the same survival doing ablation, but now if you're at a center where they have extremely good surgical expertise, but maybe not as evolved of an IR expertise, and they can't really offer ablation with those outcomes, then the patient may lean towards surgery. So I think there should, and this is a normal part of the consent and workup of really any disease, not just pertaining to this, is that patients are offered different treatment options and the pros and cons are discussed. And ultimately, it's really going to come down to discussion with the patient, but also discussion between the different teams. And quite often, it's going to be a combined approach. Especially if you have multiple lesions.
And then I have a question, but first off, I want to thank everyone for their time and for this really well done, comprehensive breakdown of the trial. Thank you so much for doing that. It's kind of tangential to the question that Arti had. It was basically, I was wondering if there was any cost analysis done and if there is going to be a difference between the financial burden of the patients who decide to pursue surgery versus ablation. Like, does ablation alleviate some of that financial burden? And how accessible is this in different countries that may or may not have the technology yet? Do you foresee that being a barrier? What do y'all think?
GG. Ella, what do you think?
I don't know the exact cost differences between the two, but I presume that there is a difference. I think as far as availability in different countries, I think that is definitely something to keep in mind, just kind of what each center is most comfortable with offering their patients. And I guess historically, what have been their rates of success and progression of tumors. As far as expanding this treatment to other areas, I mean, I think Fabian is great to talk about this, but I think this also really pushes interventional radiologists to be mindful of what therapies are available around the globe and to work with collaborators across other countries to encourage them to, not only learn these new techniques, but to share ways to guarantee better patient outcomes and hopefully work towards a place where we can be able to offer both of these therapies to patients and be really confident about the successes of both of them. I'm not sure if I really answered your question well.
Yeah, I think, yeah, let me just add to that. So yeah, I mean, cost analysis was not part of this, but cost analyses are not that straightforward, right? Because here, if you look at, of course, doing surgery typically is cheaper than using expensive IR equipment. But you also have to factor in here the secondary endpoints, right, which were mainly around complication rates were significantly lower with IR approaches, right? Meaning that typically those patients had a shorter hospitalization, had less, subsequent adverse events. So, if you're doing a cost analysis, you have to factor that in. So I can't give you a simple answer as to, which now would be cheaper when you look at the overall a burden on the healthcare system. But I would argue that overall, when you're comparing surgical versus IR approaches, IR is more cost effective. Okay. I can't say it now 100% for this, but I would assume that, if you really look at, factoring in cost of complications, et cetera, that IR is the more cost effective approach. And then in terms of accessibility, yeah, absolutely. I mean, even now, if you're looking at microwave versus radiofrequency ablation, radiofrequency ablation is a lot more accessible still in most parts of the world. And then, about half of the world has none of that, right? Not even radiofrequency ablation, let alone microwave ablation. And so, for instance, I've been doing IR in East Africa now for how many years? 7, 8 years. And we still don't have ablation there. We do most other things, but ablation technology is just, a little bit less accessible and expensive. And, despite us doing tips and TACE and everything else there already for several years, we still don't have an ablation device. All right. So accessibility definitely is a huge issue.
Yeah, to follow up on that, is it just cost or like how would you foresee the future of this progressing to make the access more available to other countries that don't currently have the technology? Like, do you think it's going to have to be new technology? Do you think it's going to have to be like an upfront investment for, the long-term benefits that you were describing for patients, namely like decreased adverse events and like probably lower rates of like long hospitalization stay and things like that?
Yeah, it's costs. Yeah, but as things become more mainstream, also the costs come down, right? It's just like if you look at large, TV screens at home, right? If you wanted to buy like an 85-inch screen, let's say 10, 15 years ago, you probably would have paid $10,000. Now you can buy it for $1,000, right? The same is true for medical technology. Is the more mainstream and the more these technologies are sort of bought in high numbers in high income countries, eventually more and more companies are going to start producing these. Eventually prices are going to drop and it's going to become more accessible. And already now there's more and more Chinese manufacturers, Korean manufacturers, et cetera, and prices are coming down. So for instance, in Tanzania right now, we're looking into different Chinese and Korean ablation devices that hopefully are going to be a little bit more affordable than some of the US companies. But then, I mean, also like we have to think about, it's not just about buying the machine, which may cost, I don't know, anywhere from between $20,000 and $100,000. But then it's also about the probes, right? And the companies, of course, want to make money. So a lot of them, then every single probe is quite expensive. You do have some probes that you can reuse. So, you can look into that. But, ultimately, companies want to make money, right? I mean, we as doctors want to treat as many patients as we can. And that's our main goal. And for us, it's hard to understand how anyone would not have that as their main objective. But for companies, ultimately, it comes down to how much money can they squeeze out of each device that they produce.
I have a question about thermal ablation in general. So I know in the study they talked about both microwave ablation and radiofrequency ablation. I was wondering if just, in general practice, is there typically a difference seen in the post-procedure outcomes of microwave ablation versus radiofrequency ablation? If I know that radiofrequency ablation's been around longer, so maybe like more people are more comfortable with that, but I was just wondering if there's anything you knew of.
So I can try to answer this first. I can't answer it from the clinical side, but I can answer it from the research side. So I think I mentioned, so essentially, radiofrequency ablation is a more pronounced heat sink effect than microwave ablation. And then recent advances in microwave ablation have decreased tumor recurrence, but also made it safer. So from my understanding, it seems to be preferred if there's a large vessel nearby, if that makes sense. But please correct me if I'm wrong.
What was the question?
I was wondering if between the different types or modalities of thermal ablation, so microwave ablation versus radiofrequency ablation, if there's any sort of differences in the post-procedure outcomes for the patients. I know that Emily was just talking about how they have different selection criteria for microwave versus radio.
Yeah. So first of all, I mean, radiofrequency ablation has been around much longer, right? So which is why most of the evidence for, not only colorectal tumors, but also HCC and other lesions is mostly about radiofrequency ablation, which doesn't mean that it's better, right? That just happens because of what's been around longer and there's just more research has been done with that. Now, over the past, 10, 15 years or so, it has really shifted more and more towards microwave ablation. And the reason is really mostly around that you can get larger ablation zones and that it's quicker, right? So people just like it better. Now, obviously, if you can get larger ablation zones and it's quicker, you probably also, it probably ultimately is also better, right? So at this point, again, and often it then just comes down to operator preference, right? So people are just used to using one device versus the other, one modality versus the other. But, overall, the trend is that, more and more it's going towards microwave ablation.
Is that partially because they're doing all of the meds in one session? So if microwave is slightly faster, it'll just like build up, and overall the procedure will take a lot less time?
Yeah. And, I mean, the shorter you have the patient on the table, the less likely you're going to have some anesthesia-related complication or other complication, right? So procedure time is also an important consideration. And then, if you can achieve a larger ablation zone, it means you need less probes, right? Or less repositioning of probes. So that's also obviously preferred, because anytime you do a new stick, you again have a risk of crossing through blood vessels, causing other complications. So the less needles you have to place, the better.
I see. Okay, that makes sense. Thank you. Does anyone else have any other questions? So it looks like we're heading towards the end of the hour here. Okay, if no one else has any questions, I think we will go ahead and wrap this session up now. Thank you so much to the presenters for coming up with this great and comprehensive presentation. And thank you to our faculty mentor as well for coming and spending your time on call to answer our questions. I just want to quickly, were you going to say something?
No, I just want to say again, like really, really great job. And I think it's awesome. It's my first time that I've been on this journal club, but I think it's really great. You know, I think you guys should keep getting together and reading stuff. You know, I mean, the more you read, the more you know. And you know, for me, I also hadn't read this before, so it's great learning. I think you guys did a very excellent job summarizing this really extensive trial.
For sure, definitely agreed. I also just wanted to put a quick plug in the chat for our website here. I think we have the sign up link in that, as well as the links to all our social media and our YouTube channel where we'll post the recording of this meeting. So thank you all so much for your time and for being here today.